It just covers all Oh, I don't know as many.
Good morning. For all of you who are not from Missoula, welcome to Missoula. I'm Dr. Randall Sechrist. I'm the medical director of the Montana Spine and Pain Center here at St. Pat's, and we're we're co-hosting this get-together with the American Cancer Society. I'm also this year's chair for the Montana Pain Initiative, and I thought I would give you just a thumbnail sketch of how this came to be. To my right here is Kay Norris, and you're going to hear from Kay a little bit later on this morning and tomorrow, a little more of a history about the Montana Pain Initiative, but I just wanted to sort of tell you why you're all in this room today. This started as a legislative initiative back in 2005 when Senator Carolyn Squires and the American Cancer Society took to the legislature and said, we need to address pain and symptom management in cancer survivors. And that was the initial start, and from there it grew to really looking at the chronic pain population, not just limited to cancer survivors, but also looking at the epidemiology and the vacuum that existed in chronic pain care of all ilks in Montana. So the legislature actually said, okay, do that. A task force was formed, and the task force met over a period of about 2 years and culminated in the recommendations back to the legislature and a white paper that some of you may have seen. There's actually a copy of the white paper in your binder, so you may want to take a look at that, the findings of that task force from a statewide survey. That then culminated in the Montana Pain Initiative last year. And that was kicked off with the first annual Montana Pain Initiative Conference here in Missoula last year. Now that was mainly an informational gathering to try to plan what the Montana Pain Initiative would really do or would be. What you're seeing is the second phase of that this morning with one aspect of what we think the main Montana Pain Initiative should be, and that is to convene folks in Montana who are providers or interested stakeholders in chronic pain care, and then try to figure out where we go from here. So this weekend, one aspect of this is to try to bring folks together who are involved in this endeavor throughout Montana. And it's not only an educational conference, but it's a conference that's designed to really put you guys in the same room and begin a discussion so that we can figure out what we do as the next phase and what the third annual Montana Pain Initiative Conference should look like. That's the goal. So I'm glad you're here, and I'm hoping that the next 2 days will not only give you a lot of information, but also connect people together that can begin to push that agenda and try to determine what the Montana Pain Initiative should become and how we're going to get there. One of the things that I would like to do is I think in the brochure there is a list of the planning committee that made this conference possible. Now, I would say that there is no way that we could have got this amount of people in the room without Kay Norris, who is here to my right, and Kristen. And Kristen Nice, who is the director of the state office. She's coming in the door right now. So they basically planned, orchestrated over the past 9 months. The planning committee met both teleconference and in person to try to give them advice. But the planning is down to the point where I have a 20-page script that I'm supposed to run this conference off of. I don't even have to think. I just have to read. And that's a challenge for me.
keep that coffee coming.
Yeah, that's right, that's right.
There's more out there now.
So anyway, I would like to ask that all of the planning committee members who are here stand up, and at least we owe them a round of applause. So please stand up, all the folks on the planning committee. A lot of these folks you'll hear from throughout the weekend and be able to connect with. And again, this is the beginning of a conversation. And yeah, we're going to talk to you some. We brought in some what I would consider national level keynote speakers that, again, we're very fortunate to get that caliber of speaker into Missoula, Montana. And again, that shows the work that Kristen and Kay did. So with that, I'm going to turn it over to Kay for some housekeeping, and then we'll begin with our first speaker.
Well, welcome everyone. I feel like I sort of somehow know you all personally at this point, and I'm really glad that you're here. As you know from the schedule, it is tight, and so we're going to try to stay on time, and we're already off time. So we'll just do the best we can, and we just want you to get as much information as you can, so hopefully you'll be patient with us when we get behind, which we probably will. June Dahl was scheduled to speak first. Unfortunately, she is here, but she's not feeling well at all, and so she's in her room. Also, very fortunate for us, Dr. Rudin is a colleague of hers, and he is willing to take her slides and give her talk. So it's not his talk, but he's going to do a great job. So thank you, Dr. Rudin. So we also have, oh no, I already went over values. Okay, great. And again, I think you all know because you're sitting back there, but there are comfortable chairs in the back for people who are experiencing pain or need a comfortable seat. Please feel free to go sit in those chairs at any time. And if we need more, we can bring some more in here. So the last thing in your notebook, the very last thing is the white paper that the Montana Pain and Symptom Management Task Force put together, and that is what really created the Montana Pain Initiative and our executive committee, and I'll tell you about that tomorrow. But anyway, that white paper explains what it is that we're going to be trying to do over the next 5 years. Thanks. Have a great time. Come to me if you need anything.
I'm lost without my paper. Okay, as she said, the first topic is going to be the same, but the speaker is going to be Dr. Rudin. A couple things that I would probably preface these first two talks with. One is that in my short period of time in dealing with chronic pain issues, what I've discovered is that there's way too much dogma, and there's way too much belief systems that have to do with the way we approach and treat chronic pain. You know, I think the biggest issue that chronic pain patients face, whether they're cancer survivors or chronic pain patients with other conditions, is legitimacy. There's still some question within both the medical profession, the legal profession, and the patient population whether chronic pain is a legitimate disease process. And that whole thinking taints or influences what we do as practitioners. And I think that the treatments are considered sometimes questionable, and the disease process, as I said, is considered questionable. And legitimacy is the biggest barrier, I think, that chronic pain patients face in order to get adequate treatment for their problem. Now, there's only one way I know that you actually approach dogma. And I'll tell you a funny story. My youngest son's a physics grad student, and he came home from school, or from the university, one Christmas with a t-shirt that the department made. So it's a black t-shirt with these stick figures. There's a group of stick figures on one side and one stick figure holding out his hand, and the caption says, "Stand back, I'm going to try science." Science is it. So as the planning committee decided what the first thing we had to tackle in terms of providing information, it's really looking at pain as a scientific process, and looking at the neuroscience and the epidemiology and all of the scientific evidence that we're learning about this disease process, because that's ultimately what's going to decide the question as whether or not this is a legitimate endeavor and these disease processes are legitimate or not. It's not going to be dogma. It's not going to be us arguing belief systems or anything else. It's going to be the science. So remember that. So Dr. Rudin is going to talk to us first and foremost about pain epidemiology and physiology of pain. Dr. Rudin is on the faculty of the University of Wisconsin Rehabilitation Medicine, is the medical director of the University of Wisconsin Health Pain Treatment and Research Center. And he is going to be our first speaker for the first two topics. So Dr. Rudin, welcome.
Yeah, I'll find him. Good morning. And thank you very much for being here and for your forbearance. I'm afraid I'm neither as pretty nor as wise as June Dahl, who is a dear friend and colleague, but I'm hoping that she will feel well enough to join us later. In the meantime, I will try to do her talk justice. Please bear in mind that I did pull in at midnight last night and had 1 hour to review this. So just a disclaimer, but I'm delighted to be here and thank you so much. Just before I begin, I really appreciate the invitation, and I have a lot of affinity for the Pain Initiative and for the American Cancer Society, and I'm thankful to the other sponsors. But as a two-time Relay for Life team captain and the father of this gorgeous 10-year cancer survivor over here, I am particularly pleased to be here and to be under the sponsorship of these institutions. So thank you very much for bringing me out, and I will try to make it worth your while. Okay. What we're trying to do here is set the stage for the policy and practice discussions that will be going on over the course of the rest of the conference. And these two talks actually really make a nice 1-2 combination, beginning with a discussion of the epidemiology, setting the stage of the problem, and talking about basic pain physiology so that we all have a common framework. Yes, we'll try the science. A common framework of what the problem is we're dealing with. And then in the second talk, we'll break it down into what's getting in the way and see how we might be able to circumvent some of those barriers. So we'll talk about the prevalence of pain in general, the evidence out there of undertreatment, the classification and basic physiology of pain. You won't need a graduate school degree to figure this out, but hopefully we'll be able to set the stage. Okay, why pain in the first place? Well, it is a ubiquitous human experience. We've all had it at one time or another. 90% of us have had a severe headache. 90% of us have had back pain at some time or another. And sometimes this is a good thing. It's a warning sign. There's an arrow sticking out of my backside. This is a bad thing. You know, something is wrong with the body, and you need to deal with it. But if the pain persists, it really is harmful to your body and your mind both. Even short-term pain. This is something we'll be coming back to. Even short-term pain can be harmful. It's been shown that acute pain after surgery delays healing if not managed correctly. And more we're seeing a basic science framework that's telling us that acute pain may evolve into chronic pain. If you don't treat pain adequately and maybe even preventively, things may get worse later. Once the pain gets chronic and persistent, there are a legion of adverse effects, physical, emotional, and otherwise, associated with it. And that's what we're trying to avoid. Now, a century and a half ago, surgeons said, well, if it don't hurt, it ain't gonna get better. And so they didn't treat pain all that much. It's good for you. It's a purification. The morality of relieving the pain of childbirth was questioned. You know, God gave us this pain, made this process painful. Maybe the pain belongs there. But these days, as we look at what untreated pain can really do, the priorities begin to change. And the focus, instead of on strictly curing disease, is more towards managing the symptoms as well. There was the general feeling, which still exists a lot of the time. You walk into most emergency departments. I had an ED physician tell me last week that he doesn't go a day without hearing the words drug seeker at least 5 times. There's still often a feeling that people exaggerate their pain because drugs is all they're looking for. So we've got a lot of history to overcome. Let's set the stage by talking about what pain is. There is actually a big group of people who sits around in boardrooms and figures out how to define these things. In this case, the International Association for the Study of Pain, who said that pain is an unpleasant, that's key, unpleasant sensory and emotional experience. Okay, so if you're working out and you say, feel the burn, that's not pain necessarily. Okay? An unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. It's a great definition. How do we describe pain? Burning, ripping, tearing, stabbing, pounding, whatever. It's like somebody's, throwing rocks at you. And pain is always subjective. That's absolutely key. Pain is an experience that is filtered through your personality. That's why one guy's 3 out of 10 is another guy's 10 out of 10. That's why two people with identical physical examinations, one's been working for 10 years, the other one's been on disability for 9. Everybody is different. We all learn the application of the word pain through early life injury and how we respond to it, how our environment responds to it, what our genetics tell us to do. So it's always an unpleasant and always an emotional experience, the magnitude of which can vary dramatically from person to person, which makes it darn hard to compare the experience across individuals. Margot McCaffrey, who was a nurse educator and advocate, gave this definition. Pain is whatever the experiencing person says it is, and it exists whenever he says it does. In other words, you gotta believe it. If they say it's there, it's probably there. I've been practicing pain medicine for 12 years. The number of people who really had pure psychogenic pain or were complete and utter malingerers, I can count easily on fingers and toes, and I don't have any extras. And even those with psychogenic pain, well, they've still got pain, darn it. It's just not the kind that we're used to seeing. Here's Scott Fishbane, 2000. He says, pain is like a symphony conducted by the brain with major inputs from various instruments within the body and mind sections. This sounds can vary like in an orchestra. It's often really hard to know exactly which instruments are playing, especially when those sweet, healthy melodies turn into gangsta rap. Okay? So it's very, very difficult to sort it all out. It's more than a neurobiological process. We need pain. It awakens fight and flight mechanisms. It helps us with the imperative to protect the body. It also elicits emotions and evokes memories of past painful experiences. This is a good learning thing. Once you know that bungee jumping made your back ache the next day, you're less likely to do it again because you remember. It's multidimensional. Okay, because pain evokes cognition and behavior as well as the simple physics and biology that occur in the pain system and that we'll talk about in a little bit. So there are all these different dimensions. Pain is a sensation. It affects how you feel, how you think, how you behave, and what society thinks about you. And what that means is that the pain treatment and assessment must take all of those dimensions into account. And it doesn't matter whether you're talking acute or chronic, you need to look at your person who's experiencing pain within the context of their existence. This is a whole person phenomenon. This is a holistic, if you will, phenomenon, and we need to attend to it accordingly, which moves us back from that pure disease model and more into a model of how we deal with a whole person and their existence or what it means to them. Because your function, your quality of life, your mood, your social and vocational status, your general well-being can all be changed, even by untreated acute pain, most certainly with persistent pain. Now, while we are doing lots better, and we really are, the strides that have been made over the last 20 or 30 years have been remarkable. Nevertheless, pain of all kinds is still inadequately treated, and it's a major public health problem. That's part of why we're all here today, is to try to solve that issue. Let's look at some examples. Acute postoperative pain, 73 million surgeries in this country each year. 3/4 of patients say they have pain after surgery. Okay. We'll have more detail in the next slide. The big thing is, for 80% of them, the pain is severe. That is something we should be able to do something about. More people report pain, they report more pain after discharge than they have while in the hospital. So clearly there's a breakdown of treatment there somewhere. Cancer pain remains inadequately treated at all stages. During the brief time when my own daughter needed some pain management, we were at Johns Hopkins, I was so glad that there was a pain team right there. They came in, and it wasn't just because I was a doc. They do that for everybody. They came in, okay, here's the PCA, here's what you gotta do, here's the breakthrough med, go. 1 month period of pain, managed adequately, pain went away, took it away, the end. Wonderful. We should have that service for all patients who need it. And cancer's become a chronic disease because people live. And survivors may be at special risk for poor pain control. An increasing population I see in clinic now as a rehab physician are people who come in with horrible pain after cancer treatment. And it's not so much that the cancer treatment caused the pain, it's that the cancer treatment was disfiguring or damaged a lot of tissue, and they never underwent the rehabilitation necessary to restore their function, and they didn't have the pain management necessary to help get them through that rehabilitation. So I'm looking at 10 years of musculoskeletal complications from old radiation, old thoracotomy, things that we could have taken care of earlier on. And of course, chronic non-cancer pain, the elephant in the room. 122 million people report recurrent or chronic pain in the past 12 months. Gosh, folks, we only have 300 million people in the country. 62% report having pain for more than 1 year. Big problem. Very briefly, back to the acute pain. 80% have moderate to severe to extreme pain after surgery. More of them experience pain post-discharge, and I have certainly seen plenty of people postpone surgery because they're afraid it will hurt. We have a group of surgeons at my institution, our wonderful out on the vanguard pain institution. They say, okay, you're on 80 of oxycodone ER 3 times a day. Fine. I won't be able to treat your pain, and your medicines are causing your pain. So in the months before your surgery, you must get off every opioid you're taking. And they come back to me, and they're biting their nails. They say, I would rather stay on the drugs and not have my back fixed. I don't care if I got a foot drop. You know? They're terrified. We've agreed to disagree about some of these things. Very often they just say, okay, Rudin, you handle the pills, we'll handle the surgery. Okay. You know, whatever, we have to manage the pain. The clinical outcomes are negative when you don't treat pain adequately. Longer length of stay, right? Readmissions, development of persistent pain. I had a patient go in for a same-day surgery. They wouldn't give her post-op opioids beyond 4 hydrocodone a day. They said, you're faking it. You can't possibly need more medicine than that. And so the patient lay in bed for 2 days until we finally got her pain medicine doubled, at which point she got up, walked in physical therapy, and left the hospital. So a same-day surgery becomes a 3-day surgery. This is a PhD musicologist, folks. This is not a street drug addict. And even if it were, would it have made a difference? The economic and medical implications are huge. $1 million to treat a 30-year-old with chronic pain over a lifetime. And we've given out guidelines. I've helped write some of these guidelines. Are they getting read? I don't know. They might just be coffee table books someplace. Or maybe they're in the waiting room next to Dog Fancier's Monthly. They don't appear to have had a lot of influence. Here's an acute hospital where they underdosed morphine. Parenteral morphine was routinely prescribed in doses that were very low in the relation to doses of other opioids. And in comparison with published effective doses and guidelines, they gave much less than they could have safely given. Why? Folks are scared. We're going to go into that in my talk a little later. In 30% of patients newly diagnosed with cancer, there is pain. And in 30 to 50% of patients undergoing cancer treatment, there is pain. 70 to 90% of people with advanced disease have pain. Since survivorship has tripled in the last 30 years, and survivors may have pain from treatments as well as from disease, we've got a lot of work to do. The precise data on the prevalence of cancer pain, according to this 2007 review, are not available. But a systematic literature review states that about 2/3 of people receiving anti-cancer treatment and 2/3 of those with metastatic disease have pain related to cancer or its treatment. After curative treatment, 1/3 of the cancer patients have pain. And 1/3 of those, so 1/3 of 1/3, 11% rate their pain as moderate to severe. So 11% of people cured of cancer have moderate to severe pain related either to their disease or the consequences of its treatment. And then we have chronic non-cancer pain. Now, this may sound like a real spate of facts, and I guess that's because it is. Thank you, June. But what we're going to do is expand on the impact of all this as we go through the conference and talk about what exactly we're going to do about all this. Because I sure don't have the time to talk about it in this 45 minutes. So my apologies for the disjunction. 122 million people reporting chronic or recurrent pain, non-cancer pain. This is not pain that is going to kill you in the past 12 months. So these are people who can expect to keep living and keep having pain if not treated. 2/3 of them pain for more than a year. If you look at long-term care facilities, elderly residents, 43% with pain. 1 out of 4 of them get no treatment. And if you have cognitive impairment, so you can't report your pain, you're even less likely to be treated because people don't know how to assess you if they're looking. Women, poor people, racial and ethnic minorities are at greater risk for inadequate treatment, according to studies we've seen thus far. Here are prevalences, and you can review this in the handout, but the prevalence of various chronic non-cancer pain conditions, starting with back pain, way up there in the 54.6 million range, and heading through migraine. Look at that fibromyalgia, 10% of chronic recurrent pain. That actually makes sense given that 2 to 3% of the general population epidemiology figure that's floating around. Have we any fibromyalgia patients in the room? Okay, yeah, I always ask because in a crowd this size there's always 3 or 4 of you, because it really is. Yeah, very, very common indeed. These are things we need to be paying attention to. And uncontrolled pain is expensive. Besides the physical and psychosocial expenses, the impact on the experience of the patient alone, the economic losses are staggering for those who have to deal with the ledgers of the state or the country. Osteoarthritis and back pain, $1 billion a year here. Absenteeism for arthritis and back pain, back pain $6 billion a year. Loss in absenteeism, another $12.5 billion a year in reduced work productivity. The other conditions, somewhat less economic impact, but you get the picture. These things are expensive. Okay, so we've got a lot of pain. We're not treating it adequately. This is why we're here today, in large part. In order to get a better handle on the scope of the problem, we need to understand it as well as we can. So a basic overview now, for the last few minutes, of the general physiology of pain and its classification, so that when we get into more technical details later, you'll all, not just the pain specialists, know what we're talking about. There are lots of ways to classify pain. We always have to classify stuff, right? We've got to put it in bins, this, that, the other thing. You can classify it by intensity, by time course. We've already gone into acute and chronic pain, by pathophysiology, nociceptive or neuropathic, we'll talk about that. Which tissue is involved? Which syndrome does it fall in? Cancer pain, fibromyalgia pain, migraine, chronic daily headache. And by special considerations, pain in the elderly, pain in men or women, pain in, upper Slovenians, whatever. We can break it all down. And all those classifications have meaning. Let's talk for a minute about the patient's psychological state as well before we delve more into classification. As I said before, your psychological state is a definite contributor to your pain experience. Now we're getting into the old chicken and egg question. Did they have anxiety and depression before they got pain? And does it make it worse? Or are they depressed and anxious because they have pain? The answer is yes. I really think it goes both ways. There are lots and lots of people who were trucking along relatively well until they were devastated by pain. And then there were people who already had a great deal of emotional difficulty, and when they developed a pain problem, everything got worse. So, in no case does that mean that the reason the patient has pain is because they're mentally ill or because they have emotional difficulties. No. But what it means is they are inextricably linked. And you do have to assess the psychosocial as well as the physical when you're trying to figure out what to do. So you should assess for anxiety, depression, or other psychiatric disorders for sure. But is pain sustained by psychological factors? I'd like to think it's more the experience and the reaction to pain that is altered by psychological factors. If you can't cope, if you don't have the learning styles, the coping behaviors, the training from family and society to handle it, and you're naturally anxious or depressed or whatever, either required or earlier, you're going to have more difficulty. So I don't think psychological factors keep the pain going, but they keep you from dealing with it. And that's the key difference. Then there's a phenomenon referred to as psychogenic pain. That's pain that does not appear to come from any organic structure whatsoever. Most of the cases of that I see, we actually do figure out a biomechanical cause for the pain. There are people for whom it really does seem to be a psychological phenomenon. Fine. That's important. It needs to be addressed. But they are a tiny, tiny minority of the people we're dealing with here. So magnifying the importance of that problem is, to my mind, missing the boat. Now, sometimes there are no visible signs of disease or injury at all. And that's when you get into psychogenic pain. To my mind, before you can put people in that classification, number one, you need to have a very good understanding psychiatrically of what's going on. And number two, you have to be good enough at your examination to really be able to figure out, is there just something you missed? Look at fibromyalgia, right? There's a condition where people hurt horribly from head to toe, and it's not on the MRI, and it's not on the CT. It's not broken, can't be anything wrong. Well, science is showing us more and more, and maybe that'll be another talk someday. Science is showing us more and more that that's not the case. There really are things going on. We just didn't know where to look for them. So chucking people in a basket that says they're all crazy, can't do it. Understand the psychological situation. Make sure that you do, but don't make it equal the pain. Okay. She threw me for a loop here. She talked about this over here. Okay. Well, all right, here you go. I will give you a quote from Misha Bajkonia, who is a dear colleague and friend of mine over at UW Pain Center, an internationally traveled scholar. And he says, "The term psychogenic pain doesn't mean anything, and the fact that its use continues is insulting to patients and a disgrace to the whole pain field." Thank you, Misha. You bailed me out of having to repeat the slide. I agree entirely. Let's classify by time course, acute versus chronic, okay? Acute pain is the pain that makes biological sense. This is the pain that occurs when you get injured. You say, ouch. Oh, okay, I just got mauled by a saber-toothed tiger. That hurts. I'm going to go lie down now. And I'm going to try and get better. And I'm going to get secondary hyperalgesia, so the wound really hurts and I won't stick my fingers in it. Makes a lot of sense. Then you heal up and the pain goes away. Voila. Then you have chronic pain. The pain that makes no biological sense whatsoever. And we never evolved to know how to deal with it. Cavemen with chronic pain tended to get eaten. They moved real slow and something would go and wipe them out. No biological imperative to survive with chronic pain. Totally different phenomenon. And you can have recurrent acute pain like in sickle cell or migraine. You can have cancer-related pain in the survivor, the long-term treated patient, and then the chronic persistent non-cancer pain. So when we separate this out, acute pain is considered meaningful and it's linear and it's reversible. You can treat it. Chronic pain, meaningless, can be cyclical, may not be reversible at all, doesn't always respond to the analgesics that work for acute pain. Acute pain is well-defined, recent onset. Chronic pain is more than 3 or 6 months, depending on your textbook. There are vegetative and depressive signs, no clear proximal cause necessarily. Your whole autonomic system starts adapting, as does your central nervous system, and the observable signs may be hard to detect, whereas in acute pain, darn it, you see that arrow sticking out of them, you know what the problem is. Persistent pain, then, chronic pain then persists long after that initial injury has healed, may vary in origin, duration, intensity, symptoms, and may spread to other parts of the body. How many people do we see who hurt their hand, and then they come in with lateral epicondylitis, and then they come in with shoulder pain, and then they come in with neck pain? And somebody says, they've got spreading complex regional pain syndrome. No, they don't. They haven't been using their hands. They've been guarding their whole limb, and the muscular pain is spreading right up the limb. We see it a lot. Or if you limp for a while, you may wind up with pain all the way up the spine and over to the contralateral shoulder because you're walking around looking like you're climbing a hill all day. So you need to watch out for your definition of spread. And talking about basic definitions, acute pain is a normal biological phenomenon that we expect. Chronic pain is really more of a disease-type state. Okay, how about the pathophysiological classification? Y'all still awake?
Oh, yeah.
Okay, good. All right. Nociceptive pain. Nociception means normal pain perception. Okay? So nociceptive pain is pain that is conducted through an intact nervous system and that occurs as a result of damage involving muscle or connective tissues or other tissues that send their signals through normal pathways. And people tend to describe it dull, aching, throbbing, cramping, gnawing, squeezing, whereas neuropathic pain is pain generated by an injured nervous system. And that can be an injured peripheral or central nervous system. And people talk about sharp pain, burning pain, shooting pain, hypersensitivity, the combination of numbness, a lack of feeling, with hyperalgesia or allodynia, a severe discomfort. People come into me and they say, "You're gonna think I'm nuts, but I'm numb and I hurt at the same time." And I say, "You're not nuts, and let's talk about it." Neuropathic pain does this. Now, nociceptive pain can be further subdivided into your somatic pain and your visceral pain. Visceral pain being pain from organs, which have all kinds of interesting cross-wired sympathetic and parasympathetic and somatic innervation, which is why we see all kinds of odd referral pain patterns like chest pain going into your jaw and down your arm, and kidney pain going down into your groin. Okay? Visceral pain comes from the organs, somatic pain comes from everything else that isn't nerves. So somatic pain tends to be well localized. Broke your arm, it's not your buttock that hurts, it's your arm. You know, it's usually aching, throbbing, gnawing, and you can see it from all kinds of tissue injuries, bone injuries, arthritis, bone metastases. Visceral pain, poorly localized, may be referred all over the place. You know, I've seen a lot of people get treated for hip pain when it's intra-abdominal, and I've seen a ton of people have 8 laparoscopic surgeries when their problem is myofascial. Deep aching, cramping, pressing pain. You don't necessarily have to have tissue damage, just tissue pressure, compression. Bowel obstruction does it, biliary colic does it, cardiac ischemia does it. And then neuropathic pain. June likes to use the lightning bolts. I think it's a great picture because a lot of people are talking about these lightning, burning, tingling, shooting sensations, an electrical system that has gotten cross-wired. Some of these things are like the car I had when I was 16, which had a floating ground, and I couldn't run the windshield wipers unless I opened my door. Okay. Something is cross-wired in the system. There is abnormal processing of sensory input by the peripheral or central nervous system. It's often very difficult to treat. It does respond to analgesics, but not always the traditional ones. Neuropathic pain has nothing to do with protecting or repairing the body at all, and is characterized by things like hyperalgesia, which is lots of pain where there should be a little pain, or allodynia, which is pain where there shouldn't be any pain at all. The person where you blow on them and they go, "Ah!" That's allodynia. And when you have it, it's not fun at all. It's a hallmark of neuropathic pain. Let's talk about a prototypical neuropathic pain condition that also has other elements to it, complex regional pain syndrome. Just very briefly to kind of set the stage for you. This is a nasty condition formerly known as reflex sympathetic dystrophy. Again, they got a bunch of guys in a room in Florida to sit down and drink a lot and come up with definitions. I only joke about that because I know several of the guys. Complex regional pain syndrome, type 1 and type 2, clinically indistinguishable, but type 2 means that you figured out which nerve was injured, and type 1 means you didn't. It develops after a noxious event of some sort, and there is pain that is disproportionate to that inciting event. Pain is not usually limited to a single nerve distribution, and this is hellish pain. Not only is there spontaneous pain that will not go away, with severe allodynia and hyperalgesia. These are people who can't be touched, who can't tolerate the blowing of wind on their skin, who can't tolerate clothing a lot of the time, who sleep without bed sheets because it hurts too much. And as if that weren't bad enough, the autonomic system gets out of whack as well, and you wind up with edema and abnormal blood flow. These are the single nastiest CRPS pictures I have ever seen. Your results may vary. These are awful. This is from New England Journal of Medicine, a recent review. There's been edema, there's been sweating change, there's coolness and temperature change. Healthy, functional 35-year-old guy fractures his 5th metacarpal neck in the right hand, and 21 months later presents like this. They wound up taking his arm off. Now, because of central sensitization, a topic we'll discuss in a couple of minutes, you take the arm off somebody with CRPS, and usually the stump keeps hurting. So the only reason to remove the limb is if it's just plain so bad that it's in the way of all of your quality of life. We generally do not amputate for this condition. But for this guy, apparently, there was little left to do. Most people do not progress to this point. But why we discuss this is because this is clearly a case where we see symptoms and signs of neuropathic pain, but there's also nociceptive pain because of swelling, because of skin damage, because of all the guarding and tension and musculoskeletal pain. And these people get massive osteoporosis from disuse of the limb and from metabolic alterations. And you can get painful osteoporosis if it occurs quickly. Think about transient osteoporosis of the hip, that peripartum phenomenon, and things like that. And also, bone pain from erosion from metastasis. Bones can cause bad nociceptive pain. The psychological and functional consequences are profound. Multimodal treatment is a must here. Now, here's one example of preventing neuropathic pain, and this kind of gets us a glimmer of what we might want to be doing on the horizon. Can we prevent some of these things? Can we anticipate that they're going to happen and thereby head them off at the pass using our new knowledge of what's going on with pain pathophysiology? So postherpetic neuralgia, which is a truly agonizing neuropathic pain symptom after shingles, after zoster infection, you can markedly reduce its incidence if you use the zoster vaccine to head off the shingles in the first place. And even zoster vaccine, I believe, has been used to try and just keep postherpetic neuralgia itself at bay. Sometimes it works, sometimes it doesn't. But there's a public health measure if you vaccinate older adults so they don't get shingles in the first place or they get an attenuated case, you're much less likely to have all of this morbidity. It's my hope that over time we'll develop things like immediate post-trauma cocktails that we can use to prevent abnormal nervous system sensitization and do other things to head this stuff off at the pass. Is there a helmet law in this town? No. Yeah, we don't have one in Wisconsin either. I've been kind of wondering about that. There's another good pain prevention tactic. Okay. All right. Pain for us clinicians as well as for the patients. So goals, so very briefly moving into pain physiology, just so you know what the highway is. Let's talk about the key concepts and structures that mediate the transmission of pain and also recognize that the nervous system, unlike I-95, sorry, I'm from Boston, is plastic. It can change itself. The map is not the same all the time. Well, in Boston, the map is never the same all the time if you've ever been there, but the nervous system is very plastic, and rewiring may be key to the development of neuropathic pain. So nociception is the perception of normal pain signals, or noxious signals rather, from the periphery through the spinal cord, brainstem, and thalamus to the cerebrum. And pain is that conscious perception when the stimulus reaches the brain, gets interpreted, gets given its cognitive and affective charge, and you feel it. It's the body's early warning system. It's vital to effective bodily function. People who have congenital insensitivity to pain tend to live short, unhappy lives. And there have been some. There was one written up recently. There was a 12-year-old. The guy had wanted to study, and so he went to study this kid, and he kept missing him. And it turned out the kid would, this was down in Central America, and his friends would dare him all the time. He'd jump off roofs because he didn't feel it. So he'd smash things up, but he'd get up and he'd say, hey, I don't feel it, I'm great. And he kept doing this, and one day, right before the guy arrived to do his blood sampling and genetics testing, kid jumped off a roof, landed on his head, and that was the end of him. You need to have pain in order to protect yourself and in order to say, this is probably a really dumb idea based on prior experience. Nociception is divided into 4 basic components that we'll run through quickly. How am I doing on time? Nobody's yelling at me yet. Okay. Transduction, transmission, perception, and modulation. Okay. First, we have transduction. Primary sensory neurons, nerve endings, nociceptors, are activated by stimuli capable of causing tissue damage. Things like heat, pressure, inflammatory chemicals, which we'll talk about in a minute. They excite nociceptors. Nociceptors are designed not to respond to light touch or warming or cooling or things like that at low levels. And the impulse generation begins. How do you get impulses up the nervous system? You have to cause an action potential. So as you stimulate the nociceptor, its membrane permeability increases. Inward current, influx of sodium, depolarizes the membrane, activates voltage-gated sodium channels. You get a burst of action potential, whoop, coming right up the afferent neurons, right up the A delta and C fibers, heading to the dorsal root ganglion where they synapse, and then heading to the dorsal root of the spinal cord. So transduction is step 1. Take pain, translate it into electricity. Okay, so here we are. And there are not just pain stimuli, but others. Okay, you get the stimuli coming in right up the afferent peripheral nerve into the dorsal horn. Okay, so you got transduction and you got transmission, right? Pain is heading up the highway once it's been created. Several neurotransmitters are released in the dorsal horn of the spinal cord, activating their receptors, because you've got to get up to the next stage of the process. And if the noxious stimulus is intense enough, the impulses excite secondary neurons, so you go beyond just a reflex, just a withdrawal, and the nociceptive impulses head up to the higher centers of the brain. So, here we are with the afferent fiber coming in, synapsing at the dorsal root ganglion, okay, or rather, synapsing at the dorsal root ganglion, sending our secondary neuron here, which synapses in the dorsal horn. You've got crossover to the spinothalamic tract and then up, and you're heading for midbrain and brainland. Okay, and from there, okay, here's dorsal horns. We're going to head up towards brainstem, through brainstem and into thalamus, where we perceive the pain. Now, so here's the thalamus, the way station, and pain does take a couple of different pathways. It goes into the associative cortex and limbic system, which is what they call the paleospinothalamic tract, the old tract. That's the instinctive response. The response that says, man, that hurts, this is really awful. And you get the heck out of there. And then you've got the higher developed somatosensory cortex, which localizes the pain for you. Oh, this pain is in the third hair of my left nostril. Okay, so you've got spatial discrimination, and then the general affective fight or flight interpretation of pain. So we've got 2 different places. And we've got a telephone ringing, but it's not important. Sorry about that. Okay, once pain is transmitted up and interpreted, you'd think that would be the end of it. But it isn't, because we've got other mechanisms in place that allow us to further process what happens. We've got modulating circuitry. And all of us have modulating circuitry that is supposed to, if you will, turn down the volume on pain, on noxious input. Serotonergic, noradrenergic circuits, and opioids, with a lot of the mechanisms concentrated in the periaqueductal gray, provide a descending inhibitory mechanism that damps down nociception. Well, what does that mean to us? Well, what it means is that a painful stimulus becomes more bearable after we've experienced enough of it to understand what it is, what its impact might be, and what to do about it. And a perfect everyday example is something a lot of us do all the time, which is sticking your toe into a bathtub full of overly warm water. Wow, pull your foot out. 2 seconds later, most of us can stick our foot back in and it doesn't feel as hot anymore. And we can get in the tub. Did the water cool off yet? No, it didn't. But the inhibitors have kicked in. They took a whole bunch of people with chronic pain states, mostly fibromyalgia, And they compared them to a bunch of hapless medical students who didn't have fibromyalgia. And they did this little thought experiment using cold water, using hot water, and for the patients with fibromyalgia, patients with pain everywhere, pain all the time, the water was just as hot or just as cold every time until the stimulus really did change and the temperature of the water equilibrated more towards room temperature. So fibromyalgia and some other chronic pain states appear to in part be problematic because that nociceptive inhibition circuit isn't working. We can't turn down the volume properly, and therefore everything hurts when it shouldn't, and things that should hurt a little bit hurt a lot. So these are circuits that actually seem to be fundamental to our ability to get up and walk around, as fundamental as the circuitry that prevents us from being spastic all the time by turning down the volume on our muscle stretch reflexes, which, as you know, if you have a spinal cord injury and interrupt the upper motor neuron tracts, you lose control of your reflexes, and your legs become stiff, and you've got spasticity, another tonic descending system that can get disabled. So now that we're starting to understand more about the physiology of normal nociception, we can start figuring out where the problems are that lead us to abnormalities in clinical pain conditions. Some of what contributes to this is neuronal plasticity, because it turns out that while changes in the nervous system can modulate response to a noxious stimulus, if you fire a noxious stimulus at the dorsal horn of the spinal cord long enough, and it may only be a few minutes, you begin to see temporary physiochemical changes in those neurons, which eventually are supplanted by more permanent, lasting changes. You can rewire your nervous system with untreated pain, which may be one reason that chronic pain is more likely to develop if you don't manage acute pain straight out of the gate. And it's a lot of these sorts of changes that seem to underlie our fibromyalgia, perhaps some of our headache syndromes, our complex regional pain syndrome, some of the chronic low back pain we see. There's a lot going on that relates directly to the central nervous system, which is why if you cut that painful limb off, you get a painful phantom limb or a painful stump instead. The changes in the nervous system central to the periphery become permanent. Why? In part because the sensitization of the nervous system can become pathologic. Inflammation is one way that we experience pain in the first place. When tissue damage occurs, the body's imperative shifts. We're no longer just protecting against noxious stimuli. Now we have a noxious stimulus, and we're going to heal up. And inflammation accomplishes that goal by throwing out an inflammatory soup of stuff. All kinds of mediators in the tissue. Let's say you bruise yourself, cells bust open, you've got histamine, bradykinin, prostaglandins, serotonin, hydrogen, nerve growth factor, the works. Everything sensitizes these peripheral nerve endings, causing increased transmission of signals up to the dorsal horn, which then becomes more sensitized, and neurons in the dorsal horn that normally don't pick up pain signals start to transmit them to innocuous stimuli. That's why a wound in a normal person hurts around the wound and not just in it, because the receptive field of the neurons has grown. That's God's way of telling you, keep your hands out of the tiger bite and leave it alone. When those processes don't shut down, when the changes in the dorsal horn become permanent or the peripheral sensitization goes on unchecked, that's when you wind up with a chronic pain condition. That central sensitization can be seen in both the ascending and the descending pathways. We know that glutamate may be related to it. We think that, and there are other transmitters as well, we think that it can be blocked in part by COX-2, cyclooxygenase 2. It can be blocked in part by opioids. We think that rewiring of the pain pathways is a key part of the pathogenesis of neuropathic pain. The alpha-2 delta subunit of the calcium channel seems to be linked to neuropathic pain. That's why drugs that act specifically on it, there's a voltage-gated calcium channel. The drugs acting on it so far are pregabalin and gabapentin. Those drugs are very effective anti-neuropathic pain states. We have good news. Not all chronic pain conditions become a neuropathic pain state, such as chronic osteoarthritis. And in the vast majority of cases, pain vanishes after the removal of the damaged tissue. We don't know why yet. Once we know why, maybe we can take the folks for whom that desirable outcome did not occur and help move them in that direction. So, lastly then, looking at this whole pain pathway, ascending in red, descending in blue, we have drugs that will tackle all different aspects of the mechanism. Down here, since there's inflammation going on, anti-inflammatories help, and local anesthetics block local transduction. In the peripheral nerve, the local anesthetics like lidocaine, very helpful. You can use blocks, whether they're soft tissue, infiltrations, or nerve blocks. As we're heading up into the dorsal horn, local anesthetics, opioids, and alpha-2 agonists. Opioids and alpha-2 agonists also help to reduce perception and may also improve descending modulation, as in the periactoductal gray. So we've got a whole roadmap here of different places for drugs to act. As we fill in more and more of the biochemical gaps here and understand the physiology better, we'll have more places for those drugs, and maybe we'll finally figure out where some of the drugs we have now actually work. We still don't have a perfect handle on how acetaminophen works. Still working on it. Okay. So I'd like to thank you very much for your time, for your patience with an alternate speaker. I hope I've been able to get the point across. And my favorite source of cartoon humor these days for these talks is Dilbert. The dog's here for those who can't read it. I invented an external antidepressant. This is a new agent. When I'm in a bad mood, I just apply it to other people. It used to be called pepper spray. So your treatment is in the eye of the beholder for sure. I'm not June Dahl, but I'm Nathan Rudin, and I approve this message. Thank you very much for having me. We have time for questions?
Yeah, we'll take about 15 minutes for questions and answers. There's microphones in the audience there, so if you have questions, let us know. We've got about 15 minutes for questions, and then we're going to take a short break for about 15 minutes after the questions are over. So any questions for Dr. Lee?
There's a microphone here, and there's one right there. So if you just want to come up to the microphone and ask questions, that would be great.
I don't know. I thought we answered everything.
I'm sure you did. Or if you think you can yell out loud enough, you can just ask it that way. No questions?
Anybody?
Here we go.
All right.
How they work and why if you miss one day's dose it can't be back.
I'm afraid I didn't make you out entirely. It's not on. Hang on. Sorry, my children's music has been getting...
Let me sing you a tune. With Lyrica and Cymbalta, for neuropathic pain, where do they work? I couldn't see that last slide very well from where I was sitting. And why, if you miss one day's dose, does your pain immediately come back, the tingling and numbness come back? And I've noted myself with neuropathy of the feet that if I miss one day of Cymbalta, it starts in the tips of the toes, and if I miss 2 days, it moves this way halfway up the foot, and God knows what would happen if I miss 4 days in a row. And I wonder where it works. Why does it work?
Certainly. Good question.
Thank you.
And thank you. Okay. In the interest of parity, I'm going to use the chemical names for the drugs. I come from a training program where every time we used a trade name, we had to put a nickel in a jar. Lasix, 5 cents, That was Johns Hopkins medicine. Okay, well, pregabalin, or Lyrica, first of all, is an anticonvulsant medicine. It works we believe, at the dorsal horn level on a voltage-gated calcium channel. And calcium is vital in the transmission of neural signals. What it seems to do is damp down transmission of excitatory signals. What we're doing basically is blocking down unwanted signals. When you think about it, that's what an anticonvulsant does anyway, right? I mean, seizures are unwanted electrical activity in the brain that you're trying to damp down. And the same goes for the perception of neuropathic pain. The drug seems to work at the brain and the spinal cord level both by interfering directly with nerve transmission. Now, pregabalin maintains a pretty good blood level, but if you miss it, your level is going to begin to drop. And because, while the drug is helpful, we don't yet know, at least, of permanent changes that it makes to the architecture of the nervous system. We haven't, I don't know if we've even got enough clinical experience under our belts yet to really know what it's going to look like, 10, 20 years from now. But when you drop the level of a drug that's helping to maintain a state of control and damp signals down, you're going to start feeling those signals waking up. And I think that's probably the phenomenon that you're experiencing. This drug does build up a level relatively quickly, which is one reason it's nice and easy to dose and relatively easy to use, but it also goes out perhaps faster than some of the other agents. Duloxetine, the antidepressant you mentioned, trade name is Cymbalta, works primarily on serotonin and norepinephrine, which are two neurotransmitters that are directly involved not only in depression and anxiety states, but also in pain transmission. And these drugs increase the availability of serotonin and norepinephrine to the brain and the spinal cord. What they do is they prevent the mechanism that reuptakes the used stuff back into the synapses and regenerates it. It just leaves it floating around out there. Now, these drugs do seem to cause some medium-term alterations in the neurochemistry of the brain. That's one reason why, although the pain effect happens pretty quickly, the depression and anxiety effect takes a month. It seems to be two different mechanisms. But again, this is a situation where maintaining a blood level is what keeps you going. People who go abruptly off their antidepressants, whether it's for depression, anxiety, or pain, often report a very quick return of symptoms. That is only fixed when you put the medicine back in there and rebalance the system. So what you're trying to do is block at strategic places pain transmission and perception, and improve modulation, improve the dampening of the pain. Anybody else? Yes?
I don't have a question. I want to just say thank you, because your introductory talk on pain is just so critical to what I do as a pain physician. The basic science, we don't know everything about the basic science. But what we do know about the basic science is exactly what the patients tell us when they walk in the door. Okay, the patients tell us it started hurting here and it's spreading. And there's a disconnect in most clinicians. The first thing that most clinicians do if you don't have any training or background in pain is you disbelieve the patient. If you can't see it, it must not exist. And just being reminded that what little we do know about the basic science is exactly what the patients are telling you when you walk in the door. It's the first step to managing chronic pain. So thank you.
Thank you. I like to use there's a painting, Edvard Munch's The Scream, that painting? The one that got stolen, the guys here, like that. I use that in a lot of my talks because I think of the patients when I look at that slide, because these are people who are having a horrendous experience and they feel like they're crying out and nobody hears them. And a lot of the time you can't even tell what the problem is. All you can tell is that they look uncomfortable, but you can't necessarily tell why or attend to it. Now occasionally, and forgive me to the patients out there, the clinician's face looks kind of like that. You all understand that. So it's applicable in both directions. But I really appreciate what you're saying, and thank you.
I have a question for you, Paul, about what services you have available in your clinic. Because and I know we're going to hear more about that in the next day or so, but what is an issue for us is access and what sort of other people you have on your team.
Sure. Okay, and we're going to talk about that more in the second talk as we start breaking things down. But, well, we have a clinic, we have several different pieces of our pain management group, and one of the difficulties we have right now is figuring out how best to integrate that, because everybody's got kind of their own niche. We do have a lot of crosstalk, which helps. So we have something that many hospitals do not have. We have a pain resource professional senior nurse, Deborah Gordon, who is nationally active and who leads a hospital-wide, on the inpatient side, quality improvement, assessment, and policy change effort. She does a lot of educating, but a lot more of what she does, frankly, is change the policy so people have to do what's best practice. And they kind of shove it down their throats, and then they do it, and we watch the quality get better. So they're responsible for everything from making sure the JCO standards get met for pain assessment, reassessment, all the way to putting a comedy channel on the inpatient TVs, to lining up ways to get massage therapy into the inpatient wards, trying to do all of these different things. She does a wonderful job. We have an acute pain anesthesia service that handles the epidural blocks and the catheters that are needed for acute inpatients. And then we've got an interventional pain service, which is headed by another physiatrist, Nalini Segal, who do the vast majority of our image-guided injections. The neat thing about her is she doesn't just do intervention. She's a clinical physician who is incredibly meticulous and attentive and measures all her outcomes, does wonderful work. I direct what's basically the pain and headache clinics, and that's an interdisciplinary group. We've got rehab and neurology, hope to be joined by anesthesia one of these days. And we have psychologists, mid-level providers, nurses on staff, and a group of physical therapists down the street with whom we work. So we try and bring as much as we can to bear for these people. The big problem in my corner of the world is that people come in looking for a Ford, and we're trying to sell them a Toyota. They want the pain elimination clinic, and we are the pain rehabilitation and functional restoration clinic. And they don't always want what we're selling. But so we have a very large set of professionals working with us, and we're really blessed to have it.
Yeah, this is kind of a minutiae question compared to the large scope, but what about NMDA and something like dextromethorphan? Have you had any experience with that? Sure.
Well, NMDA is a glutamate receptor subtype, and blockade of the NMDA receptor may help to block central sensitization and thereby be helpful for neuropathic pain. In the case of dextromethorphan, there was talk that it might even retard the development of opioid tolerance. We've never quite shown for sure, though, that tolerance is an NMDA-mediated phenomenon. We don't use a lot of dextromethorphan in the clinic, in part because it's darned hard to come by in the doses that you really need. Misha Bajkonia tried a lot of it a few years ago. Success was very mixed, and he kind of backed down. Methadone seems to have a little bit of NMDA activity, and so might, the theory is it might work a little better for neuropathic pain than some of the other opioids. That too has not been rigorously tested, in part because methadone is such a tricky drug to use and so fraught with difficulties if you're not very careful with it. Most of the NMDA active drugs that we'd like to use for pain make you hallucinate like crazy, ketamine being the big one. There are people, however, Ron Harbutt down in Arkansas, for example, has been developing a ketamine protocol where they use sub-anesthetic doses of the drug for chronic neuropathic pain states with central sensitization. He's only published a little bit, but has some promising work out there. The trick with ketamine really is to find that dose balance, because the therapeutic window is so narrow. By the time you're feeling no pain, well, man, you're feeling no pain, and that's what the problem is. I think we're out of time. Thank you so much.